Welcome back. It is my pleasure to introduce Dr. Ben Thrower this afternoon.
Thank you. Thank you guys for showing up. I know the afternoons are always tough because everyone's had lunch and you're starting to hit that post-meal nodding. So if I see you nod off, I'll send Randy over to wake you up. So we're going to talk a little bit about depression this afternoon, and I'm going to broaden that out some and also talk a little bit about cognitive dysfunction, a little bit about fatigue, because sometimes all of those things are playing off of one another. As I was putting the talk together and looking for pictures of hurricanes and tropical depressions, it brought back somewhat bad memories for me, as that one on the top, there's obviously not Ivan, because how many of you remember Hurricane Ivan? Ivan went up and went right up the Gulf Coast, and my wife's brother and his wife and their daughter live in Mobile, Alabama. So they got the heck out of Dodge, left Mobile, and came up to stay with us in Atlanta. Well, what was left over of Ivan came right inland and went into Atlanta, and we had mild hurricane force winds and lots of rain. And as my sister-in-law from Mobile, who's a hurricane expert, looked up at some of our vents on the ceiling, the intake, she noticed that water was coming in. And she said, "You've got a leak in your ceiling." So being a good husband, I got the flashlight, went up into the attic, and we had the little 2x6 rafters without anything big to stand on them. So I was doing a delicate balancing act and looking up as I was walking along the rafters. And there was that moment of great clarity when you knew that you were going off that rafter. And I had a fleeting thought, it's okay, the rafter is gonna break my fall. And I was correct, because it broke it just like that. It was ugly from where I was. Apparently it was very entertaining from the underside, because now there were two legs sticking through the ceiling. So we had to have a drywall guy come in. But I felt better when the guy told me that the cable companies keep them on retainer when the cable guys are doing installations in your attic. Apparently that's a fairly common injury, and they wear appropriate protective devices yeah. There you go. That's a segue. So what are some of the symptoms of depression? I think it's fairly obvious when we think about, a sense of sadness is what most of us would think of, but in a lot of people it's not sadness, it's irritability. Some people with depression just get a really short fuse. It's common that when we're sitting in a room talking to someone, we've got the person with MS and their significant other, and we start questioning depression, and person with MS is saying, absolutely not, I'm doing great. Significant other nodding their head saying, oh yeah. Irritability, road raging, not putting up with frustrations in the family. A loss of interest or pleasure in things that you would normally find to be fun. So that could manifest as a lack of interest in sex, which Randy will address later, a lack of interest in eating, a lack of interest in going to the movies. The medical term for this is anhedonia, or a lack of hedonism. So your things that you would normally find fun just aren't so much fun anymore. Some people with depression sleep more. Some people with depression sleep less or have fragmented sleep, so it can go either way. Some of the other things that we see are a sense of fatigue. That's why I wanted to put fatigue and depression into the same talk, because how do we separate out what is fatigue or a lack of interest from depression versus fatigue from multiple sclerosis itself or side effects from medications? One of the clues that we can look for is, again, going back to this thought of anhedonia or a lack of interest. If there's something that you would normally want to do, going to a movie, for instance, and you want to go, your family is excited about you going, and your body is just saying, I don't think so, I'm too tired, someone unplugged my energy supply, that may be more fatigue related, so fatigue directly rather than depression. If you have no interest in going, it just doesn't seem fun at all, that may be more the lack of interest from underlying depression. Again, the reason that I put the cognitive issues in here is that one of the common symptom complaints that we hear with depression is it manifests as a memory issue. And what the person is really saying is that they have poor attention and concentration. one of the common symptoms of depression is a lack of attention and concentration. So that conversation you had 5 minutes ago, that piece of information that you just read a short time ago, when you start to try to recall that, it's not there. And it's really not that you don't remember it, it's that you never stored it in the first place. So it's really not a memory issue, it's a storage problem. This is probably more distressing to people because you would think, that event just happened a short time ago, how can I not remember it? And so a lot of the cognitive issues that we see with multiple sclerosis may tie in with depression. Fatigue will also wreak havoc with your attention and concentration. We're going to talk about this kind of circle, this three-legged stool of depression, fatigue, and cognitive dysfunction. In some people, depression may be reactive, and when we think back to years ago, most MS healthcare providers felt at one point that all depression and multiple sclerosis was reactive. You were reacting to a change in your health state, you were reacting to what MS was doing to you, maybe changing your work status, maybe changing your role in your family. So it was just a natural reaction to a major life stressor. And at different points in the MS journey, that may still be true. So you could still have a reactive depression just because maybe you had a severe relapse and you're stressed about what that relapse has done to your quality of life, or maybe you were newly diagnosed. So we still do see reactive depression. But it may also be a result of the biological changes that are going on in the central nervous system. So we do see people with MS who are doing really quite well. Their MS is under good control, they're not having attacks, they're not having progression of disability, there are no new lesions on MRI, and they're still dealing with depression. And so that may be part of the biology itself. One of the things that we hear commonly from people with MS and their families is who are dealing with biological depression is, can you show me the lesion on my MRI that's causing my depression? And I don't know how Randy feels, but I can't do that. I don't think we know the spot that is responsible for most depression on brain MRI. Our neuropsychologists friends are always wanting to do that too. They'll do neuropsychological testing and say, well, I found X on the memory testing, or I found Y on the mood testing. Show me the spot that's causing that on the MRI. And it's pretty rare in multiple sclerosis, at least on brain MRIs, that we can get that specific of correlating that spot with that symptom. Some people feel that depression might also be tied into the immunology of multiple sclerosis. So you think about the complexity of the human immune system and think of it again as an army with different cells doing different things, and those cells are sending chemicals to one another so that they can communicate. Ultimately, without treatment, this sort of communication leads to more inflammation, and there is research to suggest that some of the depression we see might be due to this immune dysregulation, so that may be part of the issue with mood changes in MS. One of the things that has always been interesting to me when we look at people with multiple sclerosis, there doesn't seem to always be a correlation between physical disability and the underlying mood. Sometimes there is, but frequently there's not. Some of my individuals that I work with who are in power chairs, who have a lot of physical challenges, seem to have adjusted very well. They're happy individuals. And then I see someone who's newly diagnosed who has a numb big toe, and life is over for that person. They're really not dealing with it well. And so we have to kind of take away the myth that depression is always correlated with the degree of physical disability, because it may not be. So here's that three-legged stool of depression, cognitive dysfunction, and fatigue. When we think about treating depression, sometimes there is a tendency to want to go to an antidepressant medication as our first option, and that may be appropriate in some individuals, but again, we've got to look at the bigger picture and realize that sometimes these three symptoms are playing off of one another, and sometimes we can impact one symptom, one yellow oval there, by treating one of the other symptoms. So we certainly have a toolbox full of different antidepressants. We've got the standard, what we call selective serotonin reuptake inhibitors. These are your Prozacs, Zolofts, Paxils, and now Celexa and Lexapro. What they've done with a lot of these medications is tried to whittle out the side effects with these drugs. So as we kind of go from Prozac, one of our original medications, to now Celexa and Lexapro, which are available in generic form, they've cut down on a lot of the side effects. Randy may talk this afternoon about some of the sexual side effects that we see with these drugs, and one of the advantages of some of the newer ones is we may see less of those sexual side effects, certainly not zero. We have what we call atypical antidepressants, so things like Wellbutrin, Effexor, newer drug Pristiq, which is very, very similar to Effexor, that may be right for some individuals. As MS centers, we try to be as comprehensive as possible, so we would like to manage depression all by ourselves, and for most people we can do that. Occasionally depression is so severe, and if we've tried 2 or 3 different medications, we may need to get some help from a psychiatrist, not us personally, but referring out. Sometimes it may be us personally too. That's another story. So my comfort level is usually if I have you on 2 antidepressants and I have gotten the dose as high as is reasonable and your mood is still a problem, probably going to get some help from a psychiatrist at that point. Psychiatrists don't do what Hollywood shows them doing on television from the old days. They're not putting you on the couch and talking about your mom and asking how you feel. They're mostly managing medications, and the options for managing mood disorders have become so many that sometimes it's nice to have that extra help to get someone back on a course. One of the things I would throw in as a sidetrack, be very cautious about manipulating antidepressant medications on your own. Some of these drugs, you might get away with it. You might be okay skipping a dose of a Lexapro or a Celexa. Some of these drugs are very unforgiving if you miss a dose. Effexor or venlafaxine would be the prime candidate. If you're on a moderate to higher dose of venlafaxine, I can tell you, you do not want to skip that medication. A friend of ours has multiple sclerosis and was on a pretty good dose of Effexor, 300 milligrams a day, and called up saying that she was having a severe relapse. She came in and she had what we call chorioathetosis. She had herky-jerky dancing movements on one half of her body, which has been reported in very rare situations as an MS exacerbation. Questioned her at length about any medication changes. Nope, taking everything. Once we got her in the hospital and we're just about to start her Solumedrol, turns out she had skipped her Effexor for 2 days. Put her back on her Effexor, and within 24 hours the symptoms had stopped. So again, just be cautious with any of these medications, but especially with antidepressants in terms of stopping those abruptly. So we don't always go straight to drugs, though, when we're treating depression. Other things may help with mood disorders. So there's a tendency for many people with depression to socially withdraw. You don't feel like going out, you don't feel like doing much, you don't feel like exercising. One of the things that we really emphasize is trying to push people back out into the community. Even if you don't feel like going out for lunch with a friend, make yourself go through the motions. So we're trying to not have you not socially isolate yourself. Exercise, physical activity has been shown to actually help with mood in a lot of individuals. So maybe in some individuals we can not go straight to a medication. We might look at lifestyle adjustments, referring you to a counselor if there are life stressors. If you're newly diagnosed, again, we might go with a non-medication route first. What about cognitive dysfunction and fatigue? Cognitive dysfunction is common in multiple sclerosis, depending upon whose survey you read. It's present in 55, 60, 65% of individuals if we do neuropsychological testing. I think in a perfect world, we would do full-scale neuropsychological testing on every individual with multiple sclerosis. We don't live in a perfect world, and there are all kinds of insurance challenges that Randy mentioned. The other problem we run into is neuropsych testing. It's just not a lot of fun. If you've ever had neuropsych testing, you know it's 6 hours of pencil and paper, right brain, left brain. We always warn individuals, you're going to come out feeling like you just took the toughest college exam that you didn't prepare for. It's designed in some ways to push you to failure to find out what you can do. With neuropsychological testing, we can sort out where are the problem areas in terms of cognition? Is there perhaps a mood issue that's confounding things a little bit? We especially like thinking about neuropsychological testing if there are vocational issues. If you're looking at leaving the workforce or changing your job, we would like to get neuropsychological testing to help guide us along that pathway. The fatigue that we see with multiple sclerosis, Randy had mentioned the other day that a lot of doctors who work with MS don't realize that fatigue is not all the same thing in MS. Actually, shifting back to cognitive dysfunction for just a second, this is that survey that I mentioned that shows the prevalence of cognitive issues. So with fatigue and multiple sclerosis, it's not all the same thing. Many people with multiple sclerosis will list fatigue as their number one symptom complaint. It's either the first or second most common reason that people change their job situation, with cognitive dysfunction being either the first or second most common, depending upon whose numbers you believe. And it is present at some point in the majority of people with multiple sclerosis. The many forms of fatigue in MS do not correlate with underlying physical disability. We'll talk some about the extra work effort of overcoming weakness or incoordination and how that might correlate with physical disability. So lassitude in multiple sclerosis. This is I didn't do anything to necessarily cause this type of tiredness. Someone just unplugged my energy supply. Other descriptors that we've heard is that it's like trying to swim with a fur coat on. Someone laid a lead blanket over me and I can't move. Overwhelming fatigue that by definition interrupts your daily activities. So if you're a little tired just because you've overdone it, but you're able to carry on, that's probably not the degree of fatigue that we would use to describe lassitude. One of the common issues, and I'm preaching to the choir here, that I think people struggle with is when the person with MS tries to describe to someone who's unfamiliar with MS that they get fatigued. Fatigue means something different, I think, to a person with MS than to a person without MS. The National MS Society has that great little brochure, but you look so good because
call your doctor.
Yeah, so we'll talk a little bit about treatments for fatigue. Make sure I'm covering everything. Yep. So some of the treatment options for that someone just unplugged me type of tiredness that we see with multiple sclerosis. Again, we're going to talk some about the medications that are out there, but we don't always want to go to that right off the bat. One of the things that we need to do when thinking about fatigue, including lassitude, is rule out other potential explanations. Are you on medications that might be contributing to your fatigue? Unfortunately, a lot of the stuff that we give people with multiple sclerosis, anti-spasticity drugs, baclofen, Xanaflex, clonazepam, can be very sedating. Sometimes with interferons, there can be some fatigue that goes along with those drugs around the time that you dose the medication. Underlying sleep disorders. There were 2 studies in the past year that looked at how common sleep disorders were in people with multiple sclerosis, including obstructive sleep apnea. When I was in training, when we thought about the person with obstructive sleep apnea, we thought about a guy, he's big, he's got no neck, snorer. And in multiple sclerosis, that may be true, but we may also see a thin female with obstructive sleep apnea. When we're suspicious of sleep apnea, one of the first clues is that the person will say, you know what, when I go to bed at night, I'm really tired. When I get up in the morning, I'm just as tired. They don't have restful sleep. Ideally, we'd like to get a little more history at that point and maybe see if there's a family member, a spouse, somebody that can observe the person sleeping and see if you get that typical obstructive sleep apnea story of snore, 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 loud snore, deep breath, and then nothing. And there's a period of silence, which if you're ever watching these individuals, seems like it goes on forever, 15, 20, 30 seconds, sometimes longer. And what you'll see if you watch someone during one of these periods of sleep apnea, their chest is going up and down, but there's no air going anywhere because they've occluded their airway. Then at some point, as that oxygen level drops low enough, the brain is going to say, you know what, I don't like this very much. And then you kind of get the and it starts over again. So they wake up Partially. The person with sleep apnea may have no recollection of actually waking up through the night, but when you look at the sleep architecture on EEG or brainwave tracings, their sleep is not normal and their sleep is not restful. Typically, if there is a weight problem, we would advise weight loss, but a lot of individuals with sleep apnea are going to end up with CPAP, one of the pressurized oxygenation devices to try to keep those airways open at night. There are other things, obviously, that can disrupt sleep. One of the cruel facts of life when you think about spasticity is spasticity can be a problem throughout the day, but a lot of times it really gets cranked up at night. So as soon as you start going to sleep, the legs start twitching and jerking, you're kicking your spouse, that can be disruptive. If you have to empty your bladder every 30 minutes, every 45 minutes, and then you have trouble going back to sleep, that's going to be disruptive to your sleep. So sleep history, medication history are part of the management of fatigue, making sure we can take any of those issues off the table. Going back to exercise again for fatigue, we would like all of our folks to be in some sort of regular exercise program. When I think about working early on with the Jimmy Huga Center, now the Can Do Center, one of the points that they make in terms of exercise, and a question that you hear commonly is, what's the best form of exercise for a person with multiple sclerosis? It's whatever the person with multiple sclerosis will stick with over a long period of time. If I tell you to get on a recumbent bicycle and you don't have a recumbent bicycle or you really hate bicycles, you're probably not going to do that. So we need to find something that's going to be appropriate for and that the person has access to over a time. So what if we've done all of that and now we need to look at a medication for managing fatigue? And we're talking about the Lassitude, the unplugged energy supply, non-exertional, typically non-heat related fatigue. We have old school amantadine or Simitril. Amantadine is an old anti-influenza drug. Studies years ago showed that about 40% of people on a good day might get an energy bump from it. It is a maintenance drug. It's something that you generally have to take twice a day, every day, to see some benefit from it. We do hear individuals occasionally that start amantadine and say, this is working really well for me, and then 3 months later, not so much. Sometimes taking a little drug holiday for a weekend or longer will help you recharge your battery and have that drug start working again. Probably the most effective medication that we have are either Provigil or Newvigil, so Modafinil or Modafinil. Neither of these drugs is FDA approved for fatigue and multiple sclerosis. How many of you have had insurance issues trying to get one of those approved for yourself? Yeah, I don't know what the magic trick is to getting Provigil and Newvigil approved. I will talk to you later if you know the magic trick.
I do.
But what is the magic trick to getting?
The magic trick is to get on the internet and get to a lot of doctors, expert doctors' papers, and send about 7 or 8 of them to the insurance company and a very demanding letter saying, this is what my doctor prescribed.
So the squeaky wheel approach.
What's the problem?
Yeah.
I call them.
So being the squeaky wheel, giving the insurance company a lot of information. One of the problems we've had occasionally now that Georgia has lots of managed care is sometimes that approach assumes that they actually care about information. The ace in the hole that the third-party payers always have, if they want to be obnoxious about it, is they can say that whatever we're prescribing, if it's off-label, is experimental and unapproved for whatever and that. If they go that route, our experience has been they're really not very interested in all the science that we send them. But I do agree, you've got to be a squeaky wheel.
So Modafinil, is that Provigil, just a different name?
Modafinil is the generic name for Provigil.
Well, should I be taking Provigil?
So
I don't take very much.
So the only difference between Provigil and Newvigil is some molecules come in a right-handed version 3-dimensionally and a left-handed version. Provigil is a mixture of those two. Newvigil is all the right-handed version of the molecule and it sticks around a little bit longer. I don't think that that's inherently good or bad. Provigil, it may be a little more flexible. It can be a twice-a-day drug. Some people get away with once-a-day dosing. Many people with Provigil and Newvigil can use those on an as-needed basis. They don't have to take it on as a maintenance drug, so just take it when you need it. you may find that the modafinil, because it lasts longer, maybe it lasts too long, and maybe it gets into your bedtime hours and is interfering with your sleep. So I don't think that one is inherently better than the other. There is generic modafinil or Provigil. In reality, unfortunately, it didn't help our pricing at all. So the generic is just as expensive as the name brand on that drug. Before there was Provigil and Newvigil, we used the stimulant drugs. So things like Ritalin and Adderall, and those drugs are still available. There is a little bit of a hassle factor that goes into using these medications. These are what we call Schedule II drugs. So these are more tightly regulated by the FDA. What a Schedule II drug requires is we can't do refills, we can't phone it in. Everything has to be a written prescription. So if I was going to give you a month's supply now, in Georgia, what they allow us to do is actually date 3 prescriptions all today. Prescription 1 is for this month. Prescription 2 says don't fill for 30 days. Prescription 3 says don't fill for 60 days. But then we've got to see you back generally on an every 3-month basis to get those refilled. These are amphetamine-like drugs, and so there is concern about addictive potential or tolerance. I will say in my experience working with people with MS over the years, I have never seen a person with MS get addicted or tolerant to the Adderall or Ritalin. I just haven't seen it. I've seen people respond too well to it, where they take a dose and they feel like they're bouncing off the walls and really don't care to take that anymore. If you, and just a little sidetrack, if you are prescribed medications like Ritalin or Adderall or painkillers like hydrocodone, OxyContin, Xanax, and you ever have teenagers in your house, lock this stuff up. These are the biggest drugs of abuse in high schools right now, and we're friends with a number of undercover police officers. They have a very, very difficult time in high schools breaking up the more sophisticated dealers in the high schools. What they're hoping the kids are doing is selling pot, because when they have the fire drills in a lot of high schools, those are not really fire drills. Those are to let the drug dogs come through and go through lockers. Well, the drug dogs will alert to marijuana, but the smarter dealers know don't sell marijuana, you just sell pills, because the drugs don't alert to the pills. And the problem, and I think it's national, but we certainly see it in Metro Atlanta, is that if you get a kid who takes a hydrocodone, they will graduate to OxyContin. They will get hooked on OxyContin. Someone's going to tell them, you know that pill that you're paying $40 a pill for on the street? I can get you a $5 bag of heroin really easy. Then they're on to heroin, and then you got a real problem. So lock your drugs up if you have any teenagers in your house. So we've got the true stimulant drugs that we can use for fatigue in multiple sclerosis. There are a couple of oddballs out there that we sometimes pull out of the hat for lassitude and multiple sclerosis. Acetylcarnitine is an over-the-counter supplement which has been studied. They did a double-blind placebo random crossover trial. What that means is they had one group of people with MS and fatigue who took amantadine. They had another group of people take the over-the-counter acetylcarnitine. They did this for 8 weeks. They stopped their drugs. They didn't know which one they were on. They stopped their medication. They were on nothing for 4 weeks, and then they flipped groups. So they didn't know at any point which they were on, and there was a period of time when they were on nothing. They did surveys, they did fatigue measures, and the patients actually preferred the over-the-counter acetylcarnitine a little bit more. It's ACETYL carnitine, CARNITINE. And it's about 1,000 milligrams a day is what you're shooting for. Another interesting study that looked at people with MS taking 325 milligrams of aspirin a day for fatigue. It's only one study that I know of that showed an improvement in energy levels, but again, just so that you know, there are some off-the-wall things out there that we can do to manage fatigue. We're going to shift over and talk a little bit about nerve fiber fatigue. This is another common type of fatigue in multiple sclerosis. In my first talk back on, what was it now, Wednesday, we showed how a normal myelinated axon should work and how normally you have the electrical potential jumping from gap to gap to gap. very quick, very efficient way to get information from point A to point B. Now we've demyelinated that nerve fiber, and you can no longer jump from gap to gap to gap, so you get these little reconducted electrical potentials in baby steps over that naked nerve fiber. The problem with... Yep, page 11. So the problem with that naked nerve fiber and those little baby steps of reconducting the electrical potential is that that's the weak link in the electrical conduction chain. So if you do an activity over and over and over again, or if you raise your core body temperature, or if you do both at the same time, you may have that electrical potential just stop altogether. You are not causing new damage, you're not demyelinating the nerve fiber, you've just drained the battery electrically. Once you cool off, rest, relax, you're recharged and ready to go. How long it takes to hit that wall across different individuals varies tremendously. And to make it even trickier is it varies within the individual themselves. Drives our physical therapists and our exercise physiologists and trainers crazy sometimes, drives people with MS crazy, that one day they can do 30 minutes of a certain exercise without their foot going numb or their vision going dim. And another day maybe it's only 15 minutes. So that line in the sand moves from time to time. And I don't know how Randy feels, but I would personally rather see the person with MS step up to that line and occasionally cross it rather than never challenge themselves altogether, because we know people with MS decondition. That is another contributor to fatigue. We would, again, rather you try to find an exercise routine, a wellness program that maybe challenges you just a little bit. And again, maybe sometimes you overdo it just a hair, not consistently. I always tell people, if you're on a treadmill or in the pool doing something and your vision goes dim, you're probably done for that day. Take a break. It's okay. So some of the cooling strategies, I like the second one the best, the Shapiro Slurpee method. So I learned this from a guy a long time ago, that things that you drink that have that consistency of a Slurpee or slushy tend to drop your core body temperature a little bit more effectively than just ice water. So if you're going to go to an exercise, drop some ice in a blender, throw some water in it, and again, you may be more effective at dropping your core temperature. Wasn't there a national day? Didn't 7-Eleven do something?
Yeah, I became the official ambassador for 7-Eleven Slurpees.
That's right. And he's got 50% off coupons in his pocket for Minnesota. Yeah. We always make the point, if you're sitting on the beach, that margaritas and pina coladas also have that consistency. Neck wraps and cool caps. So they may not actually drop your core temperature that effectively, but it certainly can help out. There are tons of products out there. Many of you are familiar with these. I know some of you have these. If you go online and you Google, cooling devices, cooling vests for multiple sclerosis, lots of different companies that are out there. It seems like there are more every year. We used to recommend, now I'm blocking it, Steel Manufacturing was one of the older ones that had been around, steel with an E on the end. They do a lot of military police applications, and we needed something in our pool at Shepherd Center. We had a problem one year in the summer in Atlanta where ideally, so we have an Olympic-sized pool, and they were trying to drop the temperature, lower the temperature. Our spinal cord injured population likes the pool warmer than our MS population, and as the ambient outdoor temperature got hotter, we were having an awfully hard time dropping the pool temperature down, so it had crept up a little bit. So we wanted to see if we could get a cooling vest that would actually withstand the chlorine and the chemicals, and you could get in and out, and Steel Manufacturing actually had something that withstood the rigors of the dunkings repeatedly. It raises a question though, so what's the ideal pool temperature? So you want to do an exercise program, you want to do aquatics, you're a little concerned, you go down to the Y and there's an arthritis program there. So what's the ideal pool temperature for multiple sclerosis?
85 you're comfortable in.
85. So we'll take both. So 85 degrees is what the national, as far as I know, they still list that in their literature as the ideal temperature. We did a literature search to see where that information came from, and I found a study of 4 individuals done decades ago that was basically where that 85 degree Fahrenheit number came from. I think the second answer is actually the more appropriate one. The best pool temperature is whatever you seem to tolerate. If you have access to an aquatics program and the pool temperature is 90, 92, Try it. See, if you get out and you're a noodle and a rag doll, that's probably too warm for you. Many people tolerate that sort of temperature. In theory, any temperature that's below your core body temperature, you should be losing heat. It's just that you lose that heat a lot more effectively the cooler the water is. One of the problems that we run into that we don't talk about as much with cool water is that some people with multiple sclerosis have temperature sensitivity that's the other direction. When they get chilled or too cool, their spasticity gets worse. So sometimes we get the water a little bit too cool. And I covered some of this the other morning, but I know some people weren't here, so I'll touch on a couple of redundant points. Gait dysfunction and multiple sclerosis. I've got the speak no evil, see no evil, hear no evil, because sometimes this is under-recognized. 39% of people with multiple sclerosis say that they rarely or never discuss mobility issues with their healthcare provider. 49% of caregivers rarely or never discuss these issues with the physician. So when we see you in the exam room, if you have mild to moderate multiple sclerosis, you may look pretty good. We may tap on your knees and check your strength, and you may still look pretty good. That may not be completely reflective of what you look like out in the community. So once we get you outside and it's hot and you're doing extended walking, maybe you do have mobility issues that we're just not seeing. So we need you to tell us about what's going on. In medical training, especially as neurologists, we are sometimes slaves to history. We love our Babinskis, where we torture the bottom of your foot. But sometimes I really do feel like we get maybe as much, if not more, information from just listening. You tell us what's going on with your body, and we may get more information from that than from torturing the bottom of your foot. Not that we don't like torturing the bottom of your foot. So gait dysfunction, kind of shifting a little bit when we think about fatigue and in multiple sclerosis. Gait dysfunction comes from a lot of different sources in MS. Spasticity obviously can affect gait. Spasticity is a double-edged sword in multiple sclerosis. Typically, in people who have somehow irritated the brain or spinal cord, whether it's multiple sclerosis, spinal cord injury, stroke, the legs want to do this and the arms want to do this. So the legs tend to want to extend, and that's, again, a double-edged sword. If you have underlying weakness, you may actually be using that extensor tone to help with transfers, to help with your walking, and frequently we can get rid of every bit of that spasticity with medications or other things, and we may actually make you walk less well by doing that. One of the things I like to do in people with multiple sclerosis is get the physical therapist involved early and often to give us some feedback on how much of that tone is the person actually using to help with their activities of daily living. And then we can go from there. When we think about treating spasticity, the first thing we want to do is remove any noxious stimuli. Noxious stimuli could be a poorly fitted shoe, it could be bladder infections, it could be a pressure sore. Anything that irritates your body can sort of rev up underlying spasticity. So take away noxious stimuli. Second step is a good range of motion program. So stretching on a regular basis. Some people with their exercise program really focus on the resistance training, the aerobics, the core strengthening. We want to balance that out with some stretching. You can have stretching exercises that are shown to you by a physical therapist. You can look at some of the free yoga DVDs that are out there, which tends to give you pretty good range of motion also. After those two things, then we go to medications. With the oral medications, again, we've got Baclofen and Xanaflex are our two old standbys. One of the keys with those drugs is go low and go slow, because if we give you too much all at once, we're probably going to make you really sleepy. If those aren't working out, we can sort of graduate into other options, sometimes looking at intrathecal Baclofen or a Baclofen pump if we're just not getting where we need to be with the oral drugs. Foot drop, we'll talk a little bit more about. We did that some of that on Wednesday. Nerve fiber fatigue we've covered. Sensory ataxia we talked about the other day. This is the I can't feel my feet and therefore I'm going to put my feet further apart. If you can't feel where your feet are at, you're always walking like you've had a drink too many. If you can't feel your feet, what does your brain use to try to make up for that lack of sensory information from down here? It's going to try to use vision as one of the backups. And so, yes, so if you have visual issues and sensory issues, that's going to make life tough. But when you think about the visual cues, so if your body is using visual cues to make up for the lack of sensory information from the feet, you don't want to take those visual cues away. You're allowed to walk and chew gum at the same time, but don't walk and talk to the person next to you, because that's just like closing your eyes. You should be focusing on walking if you have balance issues, not talking to the person next to you. Standing in the shower with your eyes closed to wash your hair, you're taking your visual cues away, and there's nothing soft to land on when you fall in the shower. Getting up in the middle of the night to go to the restroom with no night lights on. Again, you're flying blind. At home, you may have compensated because you know where all the furniture is. If it's daylight hours, you know where your spouse is and you're grabbing onto them. But it's when you don't have those things to lean on, or you're in a strange environment, that we see a lot of potentially preventable falls that are going to happen. With the sensory ataxia, we don't have a way of fixing that yet. But again, the core strengthening tends to help compensate for that. And then cerebellar dysfunction. This affects your coordination in the arms and legs and in the trunk, and this looks like a really big tremor. So this is the person who wants to reach out to grab the glass, and the hand is really tremoring, and the closer they get, the worse it gets. Many people with cerebellar dysfunction have perfectly normal strength, but their walking is significantly affected because of that lack of coordination. How many weren't here for the foot drop? Should we go over this one more time? We got a handful. We'll just go over it quickly. So this is kind of one of my soapboxes I get on, because I think a lot of our community neurologists really under-recognize the importance of foot drop or ankle dorsiflexor weakness. So again, 3 weakest muscles in the legs in people with MS: ability to get your toes up off the floor, ability to bend your knee, and the ability to flex your hip. If it was just the ability to get your toes up off the floor, you would do something called a steppage gait. You bring the knee up higher when you're walking, but because your ankle dorsiflexors are weak, chances are your hip flexors are weak. And so you end up doing something called circumduction, swinging the leg out and around to walk. Not a normal gait pattern, very fatiguing. It's going to contribute to the underlying fatigue if you do that all day long. And we tend to prescribe ankle foot orthotics, which look like that, and which many people feel like that about. Great for some people, not for everybody. Alternatives: the toe-off device, a little bit lighter, maybe not as sturdy. We've actually had some patients who are really vigorous in their walking, or they're trying to do stairs a lot, sometimes actually break those. The Dorsey strap, cheap, over the counter, good if you got just a little bit of foot drop, not good if you've got a really severe foot drop, and it absolutely does nothing for lateral instability. The walk aid and the Bioness devices. Electrical devices are going to stimulate the peroneal nerve, the nerve on the outside of your knee. It's going to make your foot come up. If you have a significant foot drop and you've never heard of these, it's worth knowing about and getting yourself in with a physical therapist so they can give you a trial of one of these. They work great for some people, not for everybody. I'd say if there's one group that we've really struggled with the electrical devices, would probably be petite females. Sometimes the stimulus that you feel on the outside of the knee, if you're very small, is just too irritating for some individuals, but you never know until you put one on somebody. And again, this was the case study that showed a person actually doubling their walking speed. She still has the walker both with and without the Bioness device on, because she also has sensory ataxia. And although we've made her walking faster, we've not really helped her balance with that device, so she still needs her walker. I think we've covered that. And then lastly, just thinking about the sensory ataxia, some of the things that we can do for core strengthening: yoga, Pilates, hippotherapy, Swiss ball exercises. I can't remember where I heard that originally either. That's old school yoga ball. Physical therapists can show you some really simple ways, as long as you've got someone to help you out at home, to use a yoga ball for very effective core strengthening. The young man in the picture is doing the exercise classes is Blake, one of our exercise physiologists. one of the things that we realized at Shepherd Center years ago is that we were doing an awful lot of drug trials. Usually we have about 15 clinical trials looking at usually disease-modifying therapies, sometimes symptomatic therapies. We had this whole army of physical and occupational therapists, and we weren't doing as much rehab, wellness-based research. We really wanted to hire a PhD level researcher who was focused on wellness. And just happened to have one fall into our laps. A lady named Deb Backus is a PhD neuroscientist, physical therapist who had mainly done research in spinal cord trauma and really wanted to shift over and try to now focus on multiple sclerosis. So we were given a significant grant by the Andrew C. Carlos family to hire this wonderful lady, and she's really sort of ramped up to complement the drug research with wellness-based research. Funny story on the Carlos family. This is not their original name. It was something more along the lines of Carlosopoulos. They were from Athens, Greece. One of their ancestors, a couple of generations back, moved to Georgia, found himself in Athens, Georgia. Opened a bar in Georgia and became very successful at it. They grew that into national distributing. I think they're the second or third largest alcohol distributorship. So when you're having your glass of wine, you're supporting multiple sclerosis. Yes, very giving family. Yep, absolutely. I can remember with one of the family members who is a patient, he was a little distraught because with his strength issues and with his balance issues, he was going to have to sell his last Harley Davidson. And he came in kind of sad-faced one day and said he had sold his last Harley Davidson. And then he perked up and he said, but there's a blue Maserati in the garage with hand controls in it. So kind of made up for it.